My name's Dave Parda, and I'm an internist first and a radiation oncologist second, so I try to act like a real doctor and not just dose and target radiation every day. I've been asked to speak about central IRBs based on my experience in a large health system where we deliver healthcare services and provide clinical trials at many locations. Also based on my work with the cancer cooperative groups, namely the NSABP, whose operations center is based at my health system and our primary quaternary hospital, Allegheny General Hospital in Pittsburgh. And through my work with the NCI Central IRB from 2006 through 2013, the last 2.5 years was when I was the chair of that group. So this is Allegheny General Hospital in Pittsburgh. I'm since 2000, I've been the chair of radiation oncology. Since 2008, the chair of our institutional review board. Since 2010, the chair of the Cancer Institute. And since about 2002, working with the NSABP to design clinical trials. We have academic affiliations with Drexel and Temple trained medical students at our hospital, and have recently formed affiliations with Carnegie Mellon University and Johns Hopkins also. This shows our health system, 7 hospitals, 2,100 physicians located in a broad geographic region throughout Pittsburgh. Many services throughout this region, including cancer services that are delivered at about 25 different sites with about 150 oncologists. So we treat more than 10,000 cancer patients per year. So in order for us to manage this, we've really gotten a lot of great guidance from the Institute of Medicine and their thoughts on the fact that we need to integrate patient care, education, research and development, and community outreach within a context to improve the health of patients and populations. We've also really followed the innovation concepts of Clayton Christensen and have found it very helpful to think about things in terms of sustaining technologies versus disruptive technologies. And we really focus on configuring sustaining technologies or standards of care in the community, and disruptive technologies and advancing care at the quaternary and tertiary hospitals. This shows the configuration that we put together for the radiation oncology department that we're now extending to all of cancer. Our health system's only 10 months old. We just formed a health system with the large insurer in Pittsburgh called Highmark Blue Cross Blue Shield. So we're extending this integration work from the delivery side to the finance side, and we're really trying to drive integration and innovation by focusing on these 3 outcomes, quality, experience, and cost in these areas. And we're trying to be as explicit as possible as we map it out for our cancer patients. The affiliation with Johns Hopkins that we have recently been working on and are completing a definitive agreement on helps us extend our work from the local and regional area to a national area. We're focusing on clinical collaborations, medical education, cancer research, and really staying focused on this integration and innovation platform. We really want to accelerate knowledge transfer and treatment advances to the community. And we have the ability, if we organize ourselves, to really do a lot more with regard to phase 1, 2, 3 drug, device, and molecular studies as we work together. So this shows the number of studies clinical studies that we do at Allegheny Health Network. About 650 of these are at the main quaternary care teaching hospital, Allegheny General Hospital, which is about a 500-bed hospital where we train 500 residents and fellows, and about 100 are done at another city hospital, West Penn Hospital, that focuses on women's and infants' health, and liquid tumors, and the other 50 are diffused out into the community, and we know that we need to diffuse much more of this out into the community. So my work with IRBs started after this experience with designing the partial breast versus whole breast irradiation trial. We started designing this in 2002, and were able to finally activate it in 2005 after 3 years of work. And then after that, we were pretty much ready to go, but as one of the previous speakers said, our IRB wanted to, really hold us up for another 200 days to get it activated. So we design a lot of clinical trials at our institution, and the IRB was really bringing some of the work to a grinding halt, and that's especially problematic with a low-risk phase 3 clinical trial that has gone through so much vetting. I thought that some of my NSABP colleagues were going to spontaneously combust when it was taking 200 days to get their phase 3 studies up and running. And interestingly, our IRB was run by a very smart neurosurgeon who was an expert in biostatistics and clinical trial design, teaches at Carnegie Mellon, and was very well intentioned, and we had a smart and dedicated clinical nurse working with him to run the IRB, but they really didn't, their intentions were good, but they didn't know how to run the IRB. This is just some of our data from that we had to really improve, and you can see with the NCI Central IRB facilitated review process, we were able to get these trials activated in rather than 100 to 200 days in 15 days. So we experienced what my MD Anderson colleagues wrote about in terms of regulatory fundamentalists and regulatory rationalists, and I mean, it's a real thing despite people's good intentions, and really what my neurosurgical colleague, who's a colleague of mine, we take care of patients together, he really thought that his role was to be judge and jury of what is good and what is worthy, rather than to facilitate research and be of service to patients relative to safety, investigators relative to advancing care, and also the institution. It's notable that when we started reconstructing this IRB in 2008, that the physician running the IRB and his administrative lead would pretty much ask the compliance department of the health system what the correct answer was, which is a good way to never do a clinical research study. So I think most people here have probably seen this data, and I've made a lot of noise about working like this being potentially unethical. And the cost is huge, $2.7 million per life year gained with clinical trials regulations. So the NCI Central IRB was formed to help reduce the administrative burden on local IRBs and investigators while promoting a high level of protection. And this occurs, as you know, from adult and pediatric IRBs, and it's done in consultation with the Department of Health and Human Services and the Office of Human Research Protection. And this started in 2001. I joined this initiative in 2006, and it really has been an incredible success in my view. Jeff Abrams, Meg Mooney, Roy Smith, John Horrigan, and many others have really done a lot of work to optimize things. The first several years were shaky, but the operational expertise and the regulatory expertise and optimizing web-based formats have had a lot to do with us improving things. And having patient advocates on the board like Laura has really helped us improve our work here. So that just shows when I started doing that. And when I started reconstructing the IRB at Allegheny General Hospital, I had to really reconcile with the humbling reality that I'm not really an operational and administrative expert in IRB. So I was fortunate to be able to hire someone from Carnegie Mellon who is an expert with operations and administrative activities with an IRB, and I'm simply a guide overseeing that. And that was really my experience on the NCI Central IRB. The Operations Center became so expert and efficient in their operations and their regulatory activities that we physicians were more of a guide. John Horgan's here, and he leads a lot of those efforts and does a great job. So we really had to be explicit in 2008 to say, you know, we're really going to balance patient safety, investigator support, and institutional compliance and not be held hostage in any one of those areas. And moving on to the IRB review models, I'm talking about the central IRB. We've talked about the problems with having many local IRBs. And also that this is really part of a human research protection program, just one part of it. So it really does require a focused and dedicated approach to clinical studies and IRB function. So this is my list of advantages and disadvantages from a local IRB. There are advantages mainly related to local knowledge and responsiveness. The disadvantages we've been talking about, but there really are a lot of reasons to outsource our IRB, so our IRB's review. So we don't just outsource our phase 3 cancer cooperative group trials to the NCI Central IRB. We've outsourced a lot of our phase 2 trials to Chesapeake and Western as well. Central IRB can be more efficient and customer friendly if they're very responsive. If they're not, it's just the opposite. So the advantages of a central IRB we've been talking about. There are disadvantages mainly related to the conflict of what's your highest priority. Get the trial activated, profit questions with regard to some of the commercial IRBs, efficiency, does that supersede protection of patients? So lack of familiarity, liability concerns, and preference for control are the big issues that all the local sites have about central IRBs. But they also are realizing that they don't have the time, money, staff, and expertise to do this work. Ethical concerns with multi-institutional studies. If you do piecemeal it out in a local manner, there really can be a lot of problems when you're trying to bring a lot of data together from a lot of institutions. So that's the main point there. In terms of these advantages, a lot of improvements in efficiency, quality, education, and bringing a lot of increased capability to the communities. It is important to have agreements in place that are explicit in order to guide this work. So these are the types of agreements and memorandum of understandings that we've put in place. I'll give you a quick overview of the NCI Central IRB. This is, as I said, an initiative that started in 2001. That's the goal, and I do think that in these 13 years, a lot of those goals have been achieved. An early phase Central IRB started in 2013, and the pediatric Central IRB started in 2004. This stat is a little bit old from 2010, but over 880 institutions enrolled, including other institutions relying on their IRB, and 41 out of the 59 NCI designated cancer centers back then were involved. The number of facilitated reviews, you can see there, over 11,000, the number of total studies available for facilitated review. So the number of stipulations decreased over time. I mean, that's really, I think, something that all of us on the board had to reconcile, that you don't have to make a change to say that you're paying attention and you're doing work, and but you have to make sure that you're still reading the protocol and paying attention. So timeline to approval, as you can see, from 2007 to 8 versus 2008 to 9, 2009 to 10, have continually improved. And that has improved despite the fact that the number of studies reviewed has increased. So it became clear a few years ago that we really needed to pursue accreditation to be validated, and really the accreditation body thought that we should really adopt this independent model. So that's what has moved forward, and as of January 1, this is an independent model where the central IRB continues to review studies as before, but the central IRB becomes the IRB of record for investigators, where the local IRB has no review responsibilities, and we take care of the local context issues. So the division of duties under this independent model, you can see what the central IRB does and what the signatory institution does there. And the benefits are that when it comes to cancer, these are oncology-specific multidisciplinary boards with wide representation from surgical oncology, medical oncology, radiation oncology, pharmacy, biostatistics, patient advocates, et cetera. And that is very hard to reproduce in every local environment. This is the help desk site. So this has given us guidance in our health system to organize our Cancer Institute Research Administration. We're organizing it around the NRG, since this covers all of the solid tumors and localized and locally advanced non-metastatic cancer. We have a medical oncology group that covers liquid tumors and metastatic cancer, and a surgical oncology group, and these are the people that are helping us expand this out throughout the region. We're trying to stay focused at the patient level with the help of these navigator groups, and have organized our work into these 12 disease sites. And this shows for breast cancer how we're really trying to break down these silos of departments and divisions. So you can see that we have primary care physicians engaged, surgeons, medical oncologists, radiation oncologists, pathologists, imaging, IT, the research people, navigation, personalized care, and other key departments, with system-wide leaders and then local leaders, so that we can really accelerate transfer out to the community and integrate quaternary and community work. So the challenges in using a central IRB, it's balancing local and central leadership and cultures. I think we've all experienced that all politics are local. The information transfer can be difficult. We're just getting a web-based system in place, and that's been really hard to do this manually. Need full-time operational and regulatory experts and support. That is absolutely key. That was my experience on the NCI Central IRB and also my local IRB. And the success is that I think it facilitates more clinical trial participation in the community, where expertise, time, and money to run IRBs and clinical research enterprises is limited. This improves the quality, experience, and cost for patients and healthcare professionals. I think it promotes a participant culture rather than a spectator culture, and improves professionalism and a scholarly approach to medical practice that most physicians embrace. I really do think this helps us overcome the finance-based silos of care and valuation that have degenerated the medical profession. And this helps integrate programs. We can really only integrate through inclusive, service-oriented approaches with both patients and healthcare professionals. And I think we all know the central mandates don't work very well. Thank you.